Welcome to Pathology Central Key Concepts. The topic of this video is autoimmune disease. Now, if you've watched a number of the videos in the Pathology Central Key Concepts series, you will notice that there will be some overlap with other videos in the collection, such as the hypersensitivity video, the autoimmune vasculitis video, and the osteoarthritis versus rheumatoid arthritis video. And the reason is that in order to discuss the pathophysiology of autoimmune disease, we need to have some examples. And it's impossible to look at these from simply a single angle. So I hope that these overlapping views of autoimmune disease will help you to understand these very complicated diseases. So with that in mind, I will begin by describing the mechanisms that lead to autoimmunity, and then to put them into an appropriate context, I'm going to analyze the pathophysiology of two representative autoimmune diseases, rheumatoid arthritis and systemic lupus erythematosus. Now, just to highlight for you, there is a much more extensive video on rheumatoid arthritis in the Pathology Central series. Now, autoimmune diseases are fairly common, affecting about 5 to 8% of the American population. Now, there are a couple of different ways that we can think about autoimmune diseases, and one approach is to consider them as whether they are organ-specific, so they cause localized tissue damage, such as what we see in autoimmune hepatitis, or whether they are systemic and affect multiple organs, and the classic example of this is systemic lupus erythematosus. Now, one of the other issues that we can see with autoimmune diseases is that we can get the deposition of immune complexes and autoantibodies that frequently will deposit in blood vessels and connective tissues. And this is why these are sometimes referred to as collagen vascular diseases or connective tissue diseases. Autoimmune diseases are often chronic, with multiple relapses and remissions that progressively damage the tissue. And the reason we see this particular pattern of disease is because recall that the immune system has intrinsic amplification loops of antigen-specific lymphocytes. And this allows a small population of antigen-specific lymphocytes to address, for example, a microbial infection. But when we're addressing self-antigens, we can get this relapse and remission in disease. Another reason why this is often chronic is because of what is called epitope spreading. So you can have an immune response to one particular self-antigen. When we get subsequent tissue damage, this can cause the release of other antigens. And in this milieu where you have a lot of cytokines and inflammatory mediators, we're going to get lymphocyte activation, and you may get an immune response to another self-antigen. So that's epitope spreading. So autoimmune diseases have a very complex pathogenesis. I say pun intended because the immune complex is part of the pathogenesis of many autoimmune diseases. And what we will see as far as the clinical and pathologic findings will be determined by the underlying immune response. So is this going to be a Th1, Th17, so T cell response, or will it be due to autoantibodies? So this is another way that we can consider these autoimmune diseases. So here is a table that breaks it down into these two various classifications, so organ-specific versus systemic, and mediated by antibodies, by T cells, and then diseases that are postulated to be autoimmune. And it's important for you to recognize that we're going to be addressing each of these diseases as you work through the different organ systems in Robbins and Kumar Basic Pathology, because each organ system has its own autoimmune diseases. As you look at this, there are some diseases here, for example, scleroderma and Sjogren's syndrome, for which we suspect an autoimmune basis, but it's not been proven. Same for polyarteritis nodosa. And then we also can see what is thought to be an autoimmune response due to an excessive immune response to commensal microbes, autoimmunity, or both. So that's what we can see here are an inflammatory bowel disease. So these are part of the reason why it is challenging for us to say whether or not something is autoimmune or not is because the pathogenesis is so complex. And in many respects, one of the clues that we have that's an autoimmune disease is that it responds to immunosuppression. So what are the factors that contribute to autoimmunity? So you need to recognize that autoimmunity is basically a genetic susceptibility times environmental factors. And when you have the appropriate lineup of your susceptibility and the environmental factors, you can get breakdown of self-tolerance leading to autoimmunity. Now, there's a lot of basic immunology that is covered in this chapter of Robbins and Kumar Basic Pathology. Please refer to that to get a deeper understanding of self-tolerance. And when we have this autoimmunity, there are three ways or three contributing factors to that. So one is a defective tolerance or regulation of tolerance. We don't know exactly what causes this to happen, but we know that this plays a role in a number of autoimmune diseases. We can also get an abnormal display of self-antigens that contributes to autoimmunity. So this can be caused by incomplete clearance of, for example, apoptotic cells, and we'll talk about that in the context of lupus. Or it can be structural alterations to proteins. So this can be a post-translational modification, which we'll talk about in the context of rheumatoid arthritis. Or it can be neoantigens that are derived from cellular stress and injury, or even the exposure of sequestered antigens. And I'll talk about that in a moment as well. Now, the third factor that can contribute to the development of autoimmunity is inflammation, or an initial innate immune response. And this is because, as you know, inflammation is a strong stimulus for lymphocyte activation. So we have abundant inflammatory mediators, and through this and the generation of an adaptive immune response, we can perhaps generate autoimmunity. Also, even just simple local inflammatory reactions can increase the risk of autoimmunity. So let's take a look first at the genetic factors. So when we think about autoimmunity, these are very complex multigenic disorders. We don't have really, we don't think about like a single gene disorder for these autoimmune diseases. There are a lot of factors in play, and that's because this is very complex pathogenesis. Now, the reason we know that there are genetic contributors to this is that we have a familial association with an increased risk in monozygotic versus dizygotic twins, as well as there are certain HLA associations. Now, I want to highlight that these genes that we're looking at, the HLA associations, as well as the polymorphisms that are identified by genome-wide association studies, are weak. These are weak associations. So keep in mind that most people with a susceptibility HLA do not get disease, and many people without the susceptibility HLA do get disease. So while this is something that may be important for research, it is not currently tremendously useful in predicting who will get a disease or how they will respond to treatment. Now, the other issue is environmental factors, and we know some environmental factors that play a role in autoimmunity. So the connection between ultraviolet radiation and cell death with the exposure of nuclear antigens is fairly clear in systemic lupus erythematosus. We know that individuals with this disease will get a lupus flare if they spend too much time out in the sun with ultraviolet radiation. Cigarette smoke is thought to perhaps chemically modify self-antigens. An example of this is in rheumatoid arthritis. We know that with microbial infections, these can cause tissue necrosis, and these are very activating for T cells. And when you have this recurrent activation, this perhaps increases the risk of breakdown of T cell tolerance. Perhaps a more direct risk of environmental factors will be antibodies to microbial antigens that cross-react with self-antigens. So molecular mimicry, an example of this would be rheumatic heart disease. If we have a local tissue injury, this can cause a release of self-antigens, which can provoke an autoimmune response. And then a classic example of this would be what is called sympathetic ophthalmia. Now, this is not a disease that you need to know about in the preclinical years as a medical student, but it is very illustrative of this particular mechanism, which is that if you get trauma to the eye, this can expose some sequestered antigens to the immune system, and you can actually get granulomatous inflammation of the contralateral globe. And then finally, we believe that hormones play a role in this because as you will see, there is a significantly higher population of females who have autoimmune diseases compared to males. And this can be due perhaps to hormones or to other genes on the X chromosome. So let's just look at that here. This is a figure from Robbins Kumar Basic Pathology, where you can see, for example, Sjogren syndrome and systemic lupus erythematosus are far more common in females than in males. Things tend to even out when we get down towards ulcerative colitis and type 1 diabetes. And we do not know what the mechanism for this sex predilection is, just that it is very common. So let's begin to look at the mechanisms that we've just discussed, and let's look at them in the context of disease. So let's begin with rheumatoid arthritis, which is characterized by the abnormal display of self-antigens. So we know in rheumatoid arthritis about 50% of the risk is inherited and is associated with the HLA-DR4 allele. And as I've mentioned before, there's an entire video just on rheumatoid arthritis and osteoarthritis, so this is an abbreviated version here. We know that in rheumatoid arthritis, we've got CD4 positive T cells that will react against a joint antigen, causing the release of cytokines. These cytokines are going to activate macrophages and synovial cells and recruit neutrophils and monocytes. With this inflammatory milieu, we're going to get the secretion of proteases that will cause cartilage destruction and bone destruction. Now, about 70% of patients with rheumatoid arthritis have antibodies to peptides that have been citrullinated, and I'll show you an example of what citrulination looks like in a moment. In this process is going to cause modification of epitopes in a variety of proteins that are found in the synovium, including fibrinogen, type 2 collagen, alpha enolase, and vinculin. And it's thought that perhaps this mimics some sort of microbial epitope. So the pathogenesis for rheumatoid arthritis, it's thought that an epitope on some citrullinated peptide, so a modified self-antigen, is presented to a class 2 HLA-DR4 molecule, which is able to bind with greater affinity than we see for other HLA types. So let's take a look at what citrullinatation does to a protein. Here you can see we have a peptide backbone. Here is the amino acid residue for arginine. This is our ketamine group here. And with a variety of enzymes, we can get replacement of this ketamine group by a ketone group, and this becomes the amino acid citrulline, which is obviously not one that is found typically, and perhaps we get an antibody response to this. So let's put this into the context of a figure looking at rheumatoid arthritis. This is from Robbins Kumar Basic Pathology. So we look here, we have our susceptibility genes, HLA or other, that give us this increased risk of failure of tolerance and unregulated lymphocyte activation. We combine that with environmental factors such as infection and smoking that can cause the enzymatic modification of our self-proteins, such as our citrullination. And this is going to result in a T and B cell response to self-antigens, which is going to include antigens in our joint tissue. So we have our Th17, Th1, and plasma cells. And these are going to drive lymphocytes, antibodies, macrophages, and immune complexes into the joint. So that's going to be the impetus for that. And with this, we're going to get the release of proteases and cytokines. Our macrophages are going to release tumor necrosis factor, bringing in additional leukocytes. We have immune complex deposition here in the synovium. And all of these proteases and cytokines are going to cause this massively inflamed and edematous synovium with cartilage and bone damage. So let's look briefly at what we see clinically. So what is the impact of this autoimmune disease? Here you can see the typical findings with the joint swelling here, as well as our radial and ulnar deviation of the joints. This is an example looking at some synovium from an individual with rheumatoid arthritis, where you can see this incredible hyperplasia of the synovium. This is a thick layer of synoviocytes, and then these papillary foldings, because the synovium is so edematous and filled with these inflammatory cells. And while we think about rheumatoid arthritis being predominantly affecting the joints, we can also see rheumatoid nodules in the soft tissue and lungs. So this is looking at a disease that is primarily driven by T cells, and which is primarily looking at a single organ system. Let's now transition over to systemic lupus erythematosus, which is characterized by a failure of self-tolerance. So as the name itself tells you, systemic, this is a multi-organ disease. It affects about 20 to 150 individuals per 100,000 in the United States, with some variation by population, and females are again affected more than males. And what we see in lupus is a wide array of autoantibodies, the most important of which are anti-nuclear antibodies, or ANAs. Several of these, we can get antibodies to double-stranded DNA, to histones, and to non-histone proteins bound to RNA, as well as nucleolar antigens. And two of these, this double-stranded DNA and our Smith antigen, which is a complex of proteins that binds to RNA, are most specific for lupus. But this is, as I mentioned, is a very complex disease, so it's not that there is a single test you can do that says, yes, this is lupus. You need to bring in your clinical exam and the clinical history, as well as laboratory tests to make the appropriate diagnosis. So while we are most focused on anti-nuclear antibodies for our diagnosis, we also need to be aware that in lupus we can get antiphospholipid antibodies. Remember, phospholipids are part of your membranes, and we can see this in about 30 to 40% of patients with lupus. And these antiphospholipid antibodies, through an unknown mechanism, can lead to thrombosis. So you need to be aware of that in your patients. In addition, we can get antibodies against surface antigens on blood cells, so platelets, red cells, lymphocytes. And because of that, we'll get opsonization of those cells, and they can be phagocytosed, leading to cytopenias. So let's break down lupus in terms of our causative risk factors. So let's begin with genes and environment, and then we're going to actually talk a little bit about some experimental findings for immunogenicity. So with our genes, what we're thinking about here is that we have susceptibility genes that interfere with the maintenance of self-tolerance. And the reason we know that there's a genetic component is because of familial associations as well as HLA associations. And in some individuals, we've identified deficiencies of classical complement proteins. So perhaps this is what leads to defective clearance of our immune complexes in our apoptotic cells. For the environment, we have the persistence of nuclear antigens. It's thought that UV radiation, which I've already mentioned, can induce apoptosis, perhaps alter DNA. It also plays a role in modulating the immune response. So for example, IL-1 released by keratinocytes. Again, we have a sex bias, with females being affected more than males. So the question here is this related to hormones or other genes on the X chromosome? And there are some medications that also play a role in the development of lupus. Now, the immunologic component here, this is mostly from experimental data, so is not something that we understand as clearly in human medicine. But what we get through these different mechanisms that have been shown experimentally is persistent or uncontrolled activation of self-reactive lymphocytes. So it's been shown that defective receptor editing or defective elimination of self-reactive B cells can be part of the failure of B cell self-tolerance. We also can see activated CD4 positive T cells that are specific for some of these nucleosomal antigens, so our ANAs, that escape tolerance and thereby stimulate B cell production of autoantibodies. So bringing in our helper T cells to have an impact on our B cells. Toll-like receptors are designed in the immune system to engage with DNA RNA, and this self-DNA and RNA can mimic microbial nucleic acids, causing our immune cells to elaborate type 1 interferons, which may activate dendritic cells and B cells and promote a Th1 response. And this engagement with this DNA and RNA, which again is initially designed for the to recognize microbial nucleic acids. In this context, where we're recognizing self-DNA and RNA, we get B cell activation. So let's look at this in a figure. This is from Robbins Kumar Basic Pathology, where we have our susceptibility genes that lead to the production of B and T cells that are specific for self-nuclear antigens that are not cleared. We have our external triggers, such as ultraviolet radiation, which is causing apoptosis of our keratinocytes, with defective clearance of our apoptotic bodies, leading to an increased burden of nuclear antigens. These two combined are going to result in the production of anti-nuclear antibodies, which then can form antigen-antibody complexes. These complexes can be endocytosed by B cells and dendritic cells, where they will interact with the toll-like receptor. And when the dendritic cell has this interaction, it's going to release type 1 interferons, which is going to then stimulate B cells and dendritic cells and B cells and T cells by this interferon to cause a persistent high-level anti-nuclear IgG antibody production. So how does this result in the findings that we see in the disease? How does this cause the pathology? So tissue injury can be caused by immune complexes, which are deposited in tissue, particularly in the small vessels and glomeruli. This is going to be type 3 hypersensitivity because they're immune complexes. So just to bring this back to you, this is looking at the autoimmune vasculitis material, where you can see where you have an antigen-antibody complex that becomes trapped here in the vessel wall. This is going to cause complement to bind, and once we get that, that's going to bring in platelets as well as recruit neutrophils, which are going to cause damage and injury leading to vasculitis. These immune complexes can also deposit in the glomerulus because of that filtration. And when we get this, again, we can get complement deposition and injury to the glomerulus. And in fact, lupus nephritis is a significant cause of morbidity and even mortality in patients with lupus. Now, as I mentioned, we have autoantibodies that bind to other blood cells. This is going to be type 2 hypersensitivity. And once they opsonize these blood cells, they'll be phagocytosed, primarily in the spleen, leading to cytopenias. And then we also can have tissue injury due to our antiphospholipid antibodies, which, as I mentioned, through unknown mechanisms can lead to thrombosis. So what do we see in lupus? Clinically, this is characterized by an erythematous or hyperpigmented malar rash, also referred to as the butterfly rash over the cheeks. This is exacerbated by ultraviolet light, and I'll show you an image in a moment. The blood vessels can be affected by fibrinoid necrosis of vessel walls as part of this immune complex deposition, which we also see in the kidneys, as I mentioned, with glomerulonephritis. This rash is caused by the deposition of immunoglobulin and complement at the dermal epidermal junction, which is going to lead to vacuolar degeneration and the skin changes, and I'll show you that in the next slide. There are also a variety of cardiovascular effects due to these autoantibodies, where we can get a fibrinous pericarditis, as well as valvular vegetations that are referred to as Liebman-Sachs endocarditis. This is actually covered in the valvular vegetations video as well. This is due to the prothrombotic state that we have in lupus due to the antiphospholipid antibodies. We can see a non-erosive synovitis with minimal deformity in our joints. This is in contrast to the significant deformity we see in rheumatoid arthritis. And then there are a number of behavioral and cognitive issues with lupus, and we don't exactly know the pathogenesis of that. It has been noted that we can get intimal proliferation in small vessels in the central nervous system, leading to occlusion, and that might contribute to that. So here we can see two examples of the malar rash. Here you can see in this individual with lightly pigmented skin, this is a very erythematous here on the cheeks. And then in an individual with a darker skin type, you can see it's hyperpigmented, but still maintains a little bit of this erythematous appearance as well. And the reason the skin has this appearance is because we are getting the deposition of immunoglobulin here at that dermal epidermal junction. This is going to then bind complement, which is going to cause this vacuolar degeneration here and those skin findings. And then this is just another example showing the Liebman-Sachs endocarditis, these tiny vegetations that are due to this prothrombotic state. So as always, here are some questions for you to review the material I've just covered. I hope you found this useful. Thank you very much for your time and attention.